some things that you can do. Now, there are women that you can just point to like this and they'll jump and scream, right? There's other people that doesn't bother them. So if you're one of the women that are, first off, you're one of the women that have very sensitive breasts, and the mammograms are rough, and a lot of that has to do with the technologies, I'll tell you the truth. You take 2 Advil an hour prior to the mammogram, it usually works. Okay? Any questions on that? Any questions that come up along? This is just to give me something to talk about where they're in silence. I start sweating. I get nervous when there's just silence. So this is what the mammograms look like. We classify the breast tissue, and we put this in reports. I love breast imaging because they're one of the first fields that actually began. Oh, hey, Sheila. Hi there. That's my ruler. It's one of the first fields of medicine that started standardizing the way you speak about the breast. So they developed what's called the BI-RADS. BI-RADS is BIRADS. It's sort of a compendium. It's kind of like the guidelines. In other words, if Dr. Mills is here and then there's Dr. Hale over in Portland, Oregon, whatever I say in a report and the way that I say this, Dr. Hale will know exactly what I mean when I say that the breast density is such and such. It's a standardization. It's very important because it sort of prevents you from just kind of ad-libbing the way you describe, because that could mean different things to different people. So this is why that we focus on the breast density like this. Now this is of the breast. This is kind of side views. This is what we call a predominantly fatty breast. Fat is this black and gray area. This is the chest muscle right here. This is great. This is what we call scattered fibroglandular tissue, which means that the breast tissue is sort of wispy throughout the breast. This is what we call heterogeneously dense. You see it's increasing as we go this way. And this is what we call extremely dense. The extremely dense breast, the cotton balls, this is the most difficult mammograms to read because the breast cancers also appear white. White on white is difficult to read. So that's why we classify the breast density and stuff. Yep. What's the difference between screening? Does anyone know the difference between a screening mammogram and a diagnostic mammogram? Okay, please join in.
Good morning, Doctor.
Hi.
Yeah, my name is Rachel Ramirez, and I actually work in public health under the Breast and Cervical Cancer Early Detection Program.
Thank you.
So we are 100% funded through the CDC. So we are screening women, underinsured, uninsured, for free pap test, pre-mammogram.
Thank you.
At least you know the screening and the diagnostic.
Okay, didn't you explain to us the difference?
Yeah, the screening mammogram is that the initial mammogram, the first time mammogram that you get when you go to the doctor. It's an initial mammogram, meaning first time mammogram, and there's no other mammogram that you have. And the initial mammogram, the next step, if you have an abnormal result, is the diagnostic mammogram. It's called diagnostic.
Thank you.
Yeah.
So, and if I correct you guys, this is what I'm here for, right? If I correct you, it means I'm just trying to educate you in the right, so you know. What is screening mammogram? You can have a screening mammogram if you are 82 years old. You've had 78 previous mammograms before. You can still have a screening mammogram at 82. You can also be, I'm being kind of extreme here, but you can be 27 and not have a screening mammogram. You can actually start off with a diagnostic mammogram. This is the difference. For you, not so important, but I just want you to understand what it is. A screening mammogram is when a woman goes in for a mammogram and she has absolutely no problems whatsoever. There's nothing that she's complaining about. There are no problems, nothing detectable. The clinician that she's seen that orders this thing, there's nothing on a physical exam. This is a routine, regular mammogram. You just go in and you get it imaged. Now, so diagnostic mammogram, this is the difference. The diagnostic mammograms, it's required that a radiologist is there at the facility at the time a diagnostic mammogram is performed. Why? The diagnostic mammogram is answering a question. So the woman had a complaint. There's something on the physical exam that's abnormal. We need to address this. It's my job to run a diagnostic mammogram and answer a question. So the radiologist cannot be off in Aruba. As good as the technology is, they cannot do a diagnostic mammogram without radiologist on site. So the difference is no problem screening, problem diagnostic, right? And it's a different way. Now, screening mammograms, a lot of times they're done in batches. So many women will go to an outlying clinic. There may be, 40, 50 to 100 scheduled for a screening mammogram in one day. They go in there, they get a couple of images, they take off. Nothing is told to you, and the screening mammograms are read usually in batches. So I used to read about 100 screens a day. It used to be on one alternator, and I just cranked through 100 screens. So now, if I'm reading the screening mammograms and I find a problem, I recommend that there be something done about that. In other words, they come back for a diagnostic mammogram. That's the difference. Now, the screening mammograms they're going to take. There are 2 standard views, but some places, MD Anderson took 3. So we always got 3. It doesn't matter if you know, but it depends. It's going to take you about 10, 15 minutes. Now, of those that have had the mammograms and those that are planning on it, and all of you will plan to have them at 40 years old, unless there's another problem. Were you scared? Go ahead.
Every time.
Every time. What about you?
Yes.
Yes.
Because it's painful.
Yeah, I know. I heard it. The 2 Advil, whatever. And the technologists, I personally promise you this, that I will be working intimately with the mammogram tech to not make this painful on the woman, the positioning and things. But some women have sensitive breasts. It just happens. Try the 2 Advil. Were you scared about anything else besides, and believe me, pain, we're going to talk about that. Anybody else scared of anything else besides the pain? Of course it is. This is the difference on the patients that I see. It's a completely different subset of patients. The women that have absolutely no problem, there's nothing on a physical exam, there's no family history of breast cancer, they are terrified of going to have the mammogram. Nothing's wrong. They're terrified. I've got cancer. I like that. I like those patients. I think it's worthwhile to practice this kind of medicine. Go ahead. Okay, what if I get called back? So we just described this. So the screening mammograms, look at the screening mammogram, there's the problem. You get called back. Now, callbacks are interesting. Radiologists, chefs, whatever, everyone is different, right? So what I read on the mammogram, it's the cotton balls. It's hard. What I read on the mammogram, I may think that there's an abnormality here where Dr. Hale may think, that's not anything, I'm not called back. Then he may see something that I don't see, and et cetera. So the callback rate is what we call that. The callback rate is going to be different per clinician. And a lot of it matters on experience and how good you are. I'll tell you that. So if I see something on a screening mammogram and I want to bring you back to work up this problem, I call that a callback, right? There is sort of a standard with callbacks. For if you read 100 screens, a standard callback rate is usually 10%. 10% if I do not have any old mammogram to compare it to, right? So out of the 100 that I read per day, I would call back, if I was pretty much on par, I would call back about 10 patients. Now, some doctors have callback rates in the 40 and 50%. No. Some, yes? Go ahead, no, speak up.
I'm glad you're dealing with the callback rates.
Yeah.
Because I'm telling you, the callback rates in Guam is higher than the national level. Because it is true to our program that we are really being cited every time that we send out our reports.
Correct.
Yearly to the CDC that our callback rates is really high compared to the national. So they're really asking our opinion here because with respect to the 2 facilities that has the same doctors reading the mammogram. So we really cannot think about the reason other than what the doctor is saying, that they are just really careful of what they saw in the initial screening or the screening. And maybe I can get your opinion on that because all the time I keep on getting the same answer.
I got an opinion about it.
Yes.
I got it. Yeah.
And also the reason for that the other facility is using the conventional as opposed to
conventional what?
Conventional mammogram.
Analog. The film screen?
Yes.
Yeah.
So, and then the two facilities we are now using the digital ones.
Okay, so there's a lot in there for me, and I thank you. When I was at Baylor and at MD Anderson too, we monitored our colleagues. I think that you should police your own. So we monitor our colleagues on the callback rate. It generates a lot of anxiety, and you should not be in the 30, 40, 50%. As well as you should not have a callback rate of 1%. You're not doing right. 10% is kind of the average.
Ours is
That-
35 to...
That's too much. Now, again, it all depends on the experience and how good you are. There's a comfort level, right? I'm gonna get into the practicalities here. Breast imaging is a very, it's difficult. It's very litigious. Doctors are scared of practicing breast imaging because of the lawsuits. I have never practiced that way, and I've never taught a fellow or a resident to practice that way. I teach them to be a good breast imager. If you're good and you know what you're doing, you don't have to worry about the lawsuit. That's what I teach. And that's the way I practice. I do not practice defensive medicine. Yes, ma'am.
So is that an opinion of the radiologist, mammographer, or the technician that's doing the...
Are you asking me if that's an opinion?
Yeah, I mean your opinion on that job, because you really is, I know,
Yeah.
our funding depends on our what we, and we had never been below the CDC guidelines.
Yeah, I can't. You know, I cannot comment on. I cannot have an opinion for another doctor. I can just tell you how I practice, right? And I can tell you what. I'm not throwing out these things for you because it's just what I think.